Okay, so good afternoon, everybody. We're thrilled to have you join us for today's breakout session on this most important topic of equitable health communication. So just a little background, the NOSOR Communications Committee helped with narrowing down a topic for this session that would be tied to the Communicating SOAR Impact rubric from the topical proficiencies. And a member of the committee had great things to say about the work of the Center for Health Literacy. And so we contacted them and they graciously agreed to present today. So help me welcome our speaker today, Allison Caballero. Allison is the director of the Center for Health Literacy at the University of Arkansas for Medical Sciences. The Center for Health Literacy's mission is to improve health by making health information easy to understand. She leads a team of expert staff who provide health communications trainings and many services, including plain language assessment and editing, Spanish translation, development of health education materials, and field testing. So thank you again for sharing your knowledge today, Allison. And take it away.
Well, thanks, Ashley. I'm super excited to be here. It's always good to be with new friends, and we've not been at this conference before, but we have definitely done our share of work with rural communities, not just in Arkansas, but maybe in some of your necks of the woods as well. And so I'm always glad to meet new people, and I hope that we can stay connected after today and that we can be a resource for you as you go about your work trying to improve rural health with the groups that you're working with. So what I hope we can do today is really paint a picture between clear health communication and the outcomes that you and the practices that you serve care most about. And so that's all of those pieces of the quadruple aim, from individual and public population health outcomes to the experience of care, the cost of care, and even in the realm of provider satisfaction. I hope I can make those connections, connect those dots for you. And then I really want to present clarity of health communication as an opportunity for health equity. I think it's an opportunity, if done well, to improve health equity. And it's also a potential challenge if not done well. It's something that can actually contribute to health inequities. And so I hope you'll leave with a clear sense of those connections as well. And then I want to give you some really tangible things to think about that you can share with your organizations to help them assess the degree to which their communication is optimal based on these outcomes, and then give them some tools to move that forward and do a better job communicating so they can get to the outcomes that they care about. So as Ashley mentioned, I'm with the Center for Health Literacy, and so I will use that term some, and I always like to just start with definitions, because often when I say the term health literacy, people have a preconceived notion that what I mean is functional literacy or the ability to read. Other times people synonymize health literacy with health knowledge about a specific topic. Someone will say, I want to do a health literacy program, and what they really want to do is a health education program. They want to improve knowledge. And so I think it's important to take a moment and kind of lay some groundwork in terms of where I'm coming from, my operational definitions for health literacy. And there are two. In Healthy People 2030, that group outlined two definitions of health literacy, where in the past, we tended to focus on the first one, the personal health literacy definition. So how well a person can find health information that's worth finding, mind you, and tell the difference, understand that information, read it, process it, and then ultimately use it to improve their health or the health of the people that they're caring for. And so in Healthy People 2030, they added a new definition for organizational health literacy, because what we found is that we tended to talk about the problem in terms of individual capacity limitations, but the solutions in terms of what providers and what organizations should do. And so they added this definition of organizational health literacy, which is basically, how well do you as an organization equitably enable personal health literacy? So if you think about it, how well do organizations equitably equip people to find good health information, to understand it and to use it. And so that's what we'll spend some time talking about today. Just again, kind of deepening that definition of health literacy and your understanding of what the skills are. When we talk about personal health literacy skills, it is well beyond reading. Obviously, if someone doesn't read well, they're going to have a hard time reading information that's presented to them in written format. But there are more skills besides that we have to pay attention to. So in public health and in healthcare, we require a lot of document literacy skills. So if you give someone an intake form to fill out, a medical history questionnaire, ask them to complete a survey, including that patient satisfaction survey or patient experience survey, those all require some different literacy skills that are beyond reading words on a page. It's all about understanding how content within a document is structured, when they're being asked a question, what they're being asked, and understanding how to respond in a way that's accurate and helpful in that setting. And then we ask people to do an awful lot of math in healthcare. So if you don't believe me, ask anyone who has diabetes, and they will tell you all about the math that they have to do each and every day to manage their diabetes. In our current situation where we're talking about risk, and we're talking about prevalence, and we're talking about coverage and protection from vaccines, a lot of math involved, and people tend to have a really hard time understanding that math that we throw out there in health communication. Oral health literacy skills are really those more face-to-face skills that are required to listen and process what's going on and articulate a response that's helpful in a healthcare environment. And then digital literacy skills, wow, this has really taken a step up on everyone's priority list in the last year and a half or so, as we rely more and more on digital communication. I'm just using this, I think it's called Ring software that I'm using to present today for the first time. So we're all continuing to develop our own digital literacy skills. And we'll talk a little bit more about that later, but the very people that you all are helping in rural America are the people that struggle with those digital health literacy skills the most. So I think we have to be, again, this is a great example of an opportunity to contribute to health equity or to add to that burden. And if we rely solely on digital health communication strategies, we're leaving a lot of people out. And so that's something to be mindful of. So in healthcare, and you know, I talk to people every day around the country who are doing work, and most of them will articulate one of these, but they don't all jump to the same one. So I want to share several different factors that healthcare and public health organizations can consider when they're thinking about why they should invest any time or resources in addressing health literacy. And hopefully some of these resonate with you and the practices that you serve. And these are just examples. There are many more, but Center for Medicare and Medicaid Services, conditions of participation, whether a long-term care facility or a critical access hospital, both have some regulatory language around providing information to patients and families in a way that is clear and understandable. And in the area of consent, and this really applies to any healthcare treatment, there's always some consenting that takes place before healthcare services are provided in any environment, in primary care, in a hospital situation, all of the above. And informed consent can't really be informed consent if the person providing that consent doesn't have a full understanding of that they're consenting to. So that makes perfect sense, but we just don't think about it. And you know, check yourself maybe if you don't want to think about your organizations, or if you don't know how they handle this. Think about the last time you were a patient or a caregiver in a clinical practice and you provided consent. Think about whether you read things, whether anyone made sure that you understood what you were consenting to, et cetera. I think everyone's seen the old American Medical Association video about health literacy, where a very articulate middle-aged woman gives a testimony about having gone in for a procedure and then coming back for her follow-up visit, and they ask her how she's doing after her hysterectomy, and she says, wait, that's what you did? Really, really kind of, you know, strong example of what can go wrong with consent, but these things do happen. The Joint Commission actually considers health literacy a cornerstone of patient safety. They recognize that all kinds of safety events, whether that's medication errors, central line infections, all of those things that we tend to be working hard to address in healthcare. Those can all be influenced by patients' level of understanding, and limited health literacy can get in the way of that. So hopefully your practices are thinking about the triple aim, or maybe the quadruple aim if they've added provider experience to their list of priorities. But we can make a connection between clear health communication and all of these. It just makes sense that if someone leaves your facility without a good understanding of how to care for themselves at home or at their next level of care, that they're going to look back on that experience as less than satisfactory. And in fact, our patient experience questionnaires generally, HCAPS, CGCAPS, others generally include questions focused on communication and how well patients were prepared to take medications and to engage in self-care and those kinds of things. We know that people's ability to care for themselves appropriately has an impact on their health outcomes. And we also know that there's a lot to be said about healthcare utilization, and that people with limited health literacy are less likely to come to you for preventive care and more likely to end up at my facility for an unnecessary emergency department visit, which comes back to bite all of us, right, with your value-based purchasing. And then in the realm of provider experience, all of your providers took on a role in healthcare because they have some desire to help people improve their health. And if we can't empower people with the tools they need to do that, that fulfillment is at risk. So again, these are just some of the outcomes that can result when health communication is not clear and doesn't reach people. Here are several more, and I won't read through all of these, and I've given you these as numbered references at the back of the slide deck if you're interested in looking these up, if you need a little bit of ammunition for the people that you work with. But not getting shots, again, presenting unnecessarily to an emergency department. People with chronic disease are more likely to struggle with all the information that they require to maintain their disease and keep it from progressing. So even unnecessary admissions, not just ER visits, healthcare cost as a whole, all of these things are directly related to problems with health literacy. So these are some examples of some of the value-based reimbursement programs that some of your practices might be engaged in. I know we have several of all of these in the state of Arkansas, so I'm sure others do as well. But again, those HCAP scores include several questions related to communication and how prepared patients felt to care for themselves after that clinic visit or that hospital stay. And then CPC Plus, I know a lot of primary care practices like those you serve are engaged in that. A large portion of their score that determines their reimbursement, their incentive pay, is built around that patient experience of care survey that, again, asks very specific questions about provider communication. And then there are also some clinical quality measures that are influenced by communication, and we'll touch back on that in a minute. So HbA1c being one of those currently for CPC Plus practices. But what a lot of these value-based reimbursement programs have in common is reimbursement or incentive payment based on patient behavior. So getting that vaccine or that immunization, not going to the emergency department after an inpatient stay, getting that child's asthma medication refilled monthly. Those are all patient decisions and patient behaviors. And those things are deeply rooted in good exchange of information. So as a health educator and as a practitioner, me a health educator, you all practitioners, we all know that health behavior is complicated. And so if we stop talking right now and you left here and you just went out into your network of providers and professionals and you said, oh, I've been really, thinking about this health literacy thing. We've got to do a better job communicating health information. And you stopped right there. You're going to get people that say back to you, yeah, but information by itself doesn't change behavior. Everyone knows smoking's bad. Some people still do it. That is absolutely true. So I want you to leave armed with a little background in health behavior theory. And this is one example. There are many theories of what explains and predicts health behavior. And this is one. This is the theory of planned behavior. But if you start on the right hand side with whatever your desired behavior is, exercise more, eat more vegetables, get your blood pressure taken daily, whatever it might be that you want your patients to do, there are a number of factors that influence their ultimate decisions, right? So this says that intention, their plans to do this behavior or not, would be the biggest influence on their actual behavior in the end. So then you back up another step and say, well, how does one form intention? And it comes from those three other areas that you see there. So attitudes. Well, how do you form attitudes? You form attitudes from what you see, what you hear, what you read, and the value that you assign those things. Subjective norm has to do with what you think other important people in your world would say about the behavior. Does my doctor think this is a good idea for me? And how much do I care what my doctor thinks? If your family, if your spouse, if your friends, if your coworkers are important, influential people in your life, knowing what they think about the behavior. Do they think that, eating healthy is silly and, something that only hippies do, then that might influence your behavior, right? And so that, again, the information load happens through conversations with those people in your inner circle, your provider being one of them, generally. And then perceived behavioral control is a lot like self-efficacy, if you heard that term. So how likely do I think it is that I can do this behavior? If my attitude and the people around me support me wanting to do it, do I really think that I can carry it off? Do I have the skills? And so for something like changing the way you eat or, increasing your movement on a daily basis, those things require some skills. And I may or may not feel like I have all of the skills to enact that behavior. And usually it's health education that gets me to the point that I feel like I have those skills. So it is complicated. Information alone does not change behavior, but clear information exchange is at the root of all of these small ways that add up to influence behavior change. Okay, so it's important, great, but isn't it easy? Don't we all learn in school how to be great communicators? And I think this is the answer here is no. There's the typical kind of communication dyad between a sender and a receiver, and each person has to develop their messages in their head and encode and decode and process that. But there's a lot of noise that gets in the way of communication being clear. And I think if I asked you, you could name the noise in a clinical environment. Sometimes it's real noise, right? It can be noisy in your clinical environments, but often it's that the person in front of you or in front of the provider is ill. And I don't know about you, but when I'm not feeling well, if I'm nauseated or have a headache or I'm sleep deprived, I'm not going to do my best learning in that state. And often that's the state that our patients and families are in when they're in our presence in a clinical environment. And so we have to pay attention to that. There are some external things that contribute to communication breakdown in a clinical environment. On the provider side, so remember, we've got those definitions of both personal and organizational skills that influence, this outcome of clear communication. So on the professional side, no, we don't all learn that in school. These are just some examples of opportunities to improve the degree to which health communications skills are taught in formal health professions training programs. We're still working on it at our academic health system. We've come a really long way, but we still have room to grow. And there are several studies out that show that a lot of, what we consider best practices in health communication are not consistently followed by healthcare providers. So there's definitely some room for improvement on that side. On the patient side, unfortunately, only about 12 out of 100 adults have proficient health literacy skills. So the previous slide about having the digital and the verbal and the document literacy skills, all of that combined, only about 12 out of 100 have it. And I'll just add, I think I'm one of the people in green. I think if I took one of those, screeners or assessments, I would be one of those people in green that has adequate health literacy skills based on what I do for a living. But I promise you, if there is an event and I end up at an emergency department or even a primary care practice with my mother or one of my children, and I'm stressed out, again, that's the noise. That's my health literacy skills going right out the window. So we really encourage providers to treat everyone as though they might struggle with health information. There are some groups that have increased risk of challenges with health literacy, and none of these are probably a surprise to you. But I want you to think about how we've seen this play out with COVID, and think about where the disproportionate burden has been with COVID. And you should see a lot of similarity in the groups listed here and the groups having the most significant undesirable outcomes from COVID, and maybe some with challenges with vaccine uptake as well. We know that our patients who are just learning English are the racial and ethnic group that are most likely to struggle with health information. And I think if you all looked at your population changes in rural areas, we see across the country increasing numbers of patients with limited English proficiency in our practices. And I think we still have some room to catch up to providing information to that group that's equitable. So again, we've seen this play out with COVID. We've seen those outcomes. We've seen the minority populations with more cases, hospitalization and death in particular, more so than cases. And this is data from several months back, but it hasn't changed a whole lot over the course of the pandemic. And we can do better with what we're putting out there for people to educate people about COVID. Our group did a study, and this was back in March of 2020, when a lot of pandemic information was really new and people were, using online sources a lot, not exclusively, but a lot for their pandemic related information. We just did a study of readability, and then we also looked at some other plain language qualities about, the likelihood that someone could take action. And almost 6 in 10 of the materials were written at kind of mid-high school level or above, making them really out of reach for a lot of people that needed that information most, And so think about the groups that struggle with health literacy, the groups that are now struggling with COVID, and we've missed the mark on providing information that's easy for them to read, understand, and use. And then beyond quality of information, we have to think about access as well. And there is a divide in access, and you all know this firsthand. But this is 2019 data that from Pew that about 3 out of 10 rural residents didn't have a smart device at home. So as we shift to telemedicine visits and we shift to providing teleeducation and posting information, health education information only online, we might be missing this important population. And likewise, those with low income. Again, these are groups that have known health literacy challenges. Groups with lower income are less likely to have internet at home than other populations. And so this can be a real challenge in disseminating information equitably. So I want to shift and talk about some solutions. I'm going to see if I can pull up the chat and see if there are any questions there. Let's see. All right, I don't see any questions there yet, but as we continue here, I am going to save some room for discussion. But if you have questions along the way, if you want to drop those in the chat, I'd be happy to kind of take a look at those here in a few. So I want to get to the nitty gritty of so what do you do about it? Because that's important. So again, thinking about those two definitions, personal and organizational health literacy, where we really have a problem and therefore an opportunity to intervene, is when there's a mismatch between those individual personal health literacy skills and the demands that we place on patients, families, and community members with our health information. So the solution is to either boost up those individual skills or to reduce those demands and expectations, right? So you can think about it this way, or you can think about it in terms of improving individual or improving organizational health literacy. So this is one example of opportunity to improve individual health literacy, because it's a little overwhelming to think about that when you go back to that earlier slide of digital skills and document skills. It's a lot. And, I think the if I was waving a magic wand, I would go all the way back to K-12 education and look for those opportunities to teach those skills as people learn. We want to teach them topical health education, right? We want to teach them, about heart health, and we want to teach them about safe sex practices and tobacco use and healthy diets. And we should do all of those things. But I don't think we do a good job generally teaching how to be an empowered healthcare consumer, how to communicate with a doctor, how to search for health information online that's authoritative and that is not based on an N of one example on someone's blog. We don't teach that. And you all have seen that. You've seen people in recent months getting information from less than desirable places with less than desirable data to back it up. And so I think there's a lot to be said and taught at that level. But just an example of something smaller scale that practices could adopt. We've got a series of handbooks, how to talk to your doctor, how to talk to your child's doctor, that are meant for people to start to learn some of those skills at any age. And we've used, these are all for adult audiences, but we've used the How to Talk to Your Doctor handbook with adolescents as well and seen some good outcomes. But it teaches them things like what kind of information they should write down in advance of a doctor's visit. And again, you can check your own skills in this and think back to your last visit when they say, what brings you in today? Were you ready with a concise statement of your kind of abbreviated health history and the main things that you that were concerning you and that you wanted to gain from your visit that day? And I know that I'm not always that prepared. I've actually used the How to Talk to Your Child's Doctor handbook several times in taking my kiddos in to make sure that I've got all those details pulled together and that I'm ready to give that concise summary statement and that I'm prepared to answer all the questions that are going to come my way. I always kind of do a, head slap when I hear the doctors say, well, okay, well, how high did the child's fever get? And I have to stop and think about it. I knew they were going to ask me that question. They always ask that question, but why didn't I prepare for that? And so these can kind of help people get accustomed to preparing for that. And we have some of these printed in our office. And if we have extras, I'm pretty sure we have extras of child's doctor. That's the main one. We might have extras of some of these others. If we have them available in our office and you want them, you can email me. I'll drop my email in the chat and I'd be happy to send them to you. We won't even charge you for shipping. If you can use them, if your practice can use them, you can have them. We have another one that's about emotional wellness, how to move toward emotional wellness. And that one's been really popular during the pandemic. And we have some of those available, I know, as well. And sometimes we have these in English, sometimes we have Spanish. So let me know what you need. And if we have it, we can get it for you. And if we don't have it, we can give you a quote on getting it printed and shipped to you. We also have at this web link that's down here, we've got some online modules. So the How to Move Toward Emotional Wellness is actually an online digital module that any provider can share with their patients. So you all can share that with your providers in your areas. But it's an online interactive self-paced tutorial that people can just learn some things they can do on a daily basis to improve their emotional wellness and again, to become better communicators with their providers about their emotional wellness concerns and needs. And then we did a follow-up to that one during COVID. That's it's how to lift your spirits during a pandemic or other hard times. And so LIFT is an acronym that stands for the 4 steps that they can remember to kind of help them keep their stress levels down during the pandemic. So these are some things that you can use to help patients and consumers become better communicators and boost some of their own skills in that area. And then really shifting toward those organizational factors. And this is where I think you can provide a lot of resource guidance to your practices. So the Institute of Medicine and the AHRQ have this framework, the 10 attributes of a health literate healthcare organization. And I think it's a really useful place for practices to start. It sounds great. Yes, we want to be great communicators, but what do we need to do in order to do that? How do we get started? And I'll say this in case I forget later, because I don't think this is necessarily one of the 10 attributes, but you can always start with an assessment. And I know that in the resources listing at the back of the slide deck, I have a link out or a title for the health literacy environment screener. And that's a great place to start to see how you're doing in achieving some of these attributes of a health literate healthcare organization. So we'll hit some highlights. And then, like I said, I do want to save some room for discussion. So a health literate healthcare organization has leadership that really integrates health literacy into possibly their mission statement, but definitely into their structure by having people who are assigned to kind of own health literacy and addressing health literacy as part of their job function, and really establishes some accountability around that. So, if you check your strategic plan, your mission statement, look at staff position descriptions, and you don't see anyone whose job it is to make sure that health communication goes off without a hitch, then there might be room for improvement there. And almost every health organization will have a person, and a small primary care practice may have really one person, or it might be 10% of someone's job in the office, right, to do communications. But we'll talk a little bit more about how that might not be quite enough. It's a good start, but they'll need some training as well. So the next attribute is integration of health literacy into planning, not just strategic planning, but project planning, plans for new facilities, plans for new service offerings, plans for safety improvement, and then also quality improvement planning. And this little chart over here, this graph, is a representation of a QI project and its outcomes that we did within our academic health system. We knew that we had certain high-risk population of patients that needed pneumococcal vaccine protection. So these were patients with compromised immune systems in our multiple myeloma and rheumatology clinics. And we were well below the national Healthy People 2020 at the time guidelines and goals for pneumococcal vaccine protection in that group of patients. And we started a QI project, and it was multifaceted. There were physicians and IT people involved and our health literacy team. But we were so grateful that they invited us to the table to be involved from a health literacy perspective. They had initially talked about needing to get, a freezer to store some vaccines in. And then they said, well, we need to know, and we need to have something fixed in our electronic health system so that when a patient is due for one of these vaccines, there's a best practice advisory and the provider can see that it's time for that vaccine. But the group said, but we're going to have to do something around patient education, because we know that this patient population they have a perception that they can't get vaccines because they're immunocompromised. And so the minute you say it, they're going to, tune you out unless you have some very solid, tailored patient education materials for them that are easy to read and use and understand. So they worked with us and we did that. And all the lines are just the different clinics, but you can see just in general that vaccine coverage went up in all the clinics and kind of sustained itself until COVID happened. It's sustained even since COVID started, but it hasn't increased. The coverage hasn't increased anymore, but the coverage nearly doubled. So that was a huge win for QI and a good example of including health literacy in that planning. So back to that workforce training, just because you have someone whose job is patient education, all of you have nurses, all of your practices have nurses that work with you, and everyone will acknowledge nursing as a central role in patient education. And many practices will name many other disciplines as being integral to patient education, and that's ideal. That's perfect. But there's so much to learn about that. So as you all probably know, and your practices probably know, but they're challenged every day with time and other barriers. Handing someone a piece of paper is not educating them. And, asking, do you have any questions, is not making sure that they understand what's been communicated to them. And, and particularly with plain language writing, People who are tasked with writing health education materials are very likely, most likely have not had formal training in how to do that in a way that checks all of those plain language boxes. And so there's a big opportunity for professional development there. And what I mean by plain language, I always like to define this too, is just readable, understandable, and actionable. It's the things that when you say it, people kind of understand it the first time you say it, or when they read it, they understand it without having to read it a second time or to question whether or not they actually understand what they've read. And we never want to refer to this as, dumbing down or watering down, because nobody wants to think about, having something dumbed down for them. And let's face it, we all benefit from clear communication. If you've read a statement of benefits from your insurance company lately, or your car's owner's manual, or a tax form, or any of those things lately, I think you'll agree that we all benefit when communication is clear and easy to follow. So another attribute of health literate care organizations is the involvement of patients and families in, the development of services, the development of those patient education materials, all of those things. And I know many of your practices will have some kind of patient family advisory committee, and I think that's a great step in the right direction. But I would challenge them to think about who's on those committees. I know that I've seen numerous examples of those really the fans, right? That the people who really appreciate your staff and your services and your facility, they're the ones that the nurse or the social worker says, oh gosh, we've got to get sweet Sally Jane on our family advisory committee. She just loves us. She just sings Dr. Smith's praises all day long. We just love her, and she's so cute, and we've got to get her in here and get her on our committee. And if you have a room full of sweet Sallys, then you're not going to get really useful feedback. You really need people who are not, haven't drank the Kool-Aid, so to speak, or that maybe have limited education. Think back to those groups who are at risk for limited health literacy. And you want to make sure that your advisory groups are made up of representatives from those groups. Again, thinking about this in the lens of health equity, if you get a bunch of well-educated retired nurses on your advisory committee, you're not going to get the same kind of useful feedback that will help those maybe otherwise left out populations, as if you had included those groups as well. And that can be difficult. Another opportunity is if your health system, and many are starting to, if your health system screens for patient level health literacy, there's several validated screeners out there that they might be using, but if they're screening for that, then they can use that as a population to pull from as well, to invite people to participate in advisory functions. So meeting the full range of health literacy skills. And so I mentioned this earlier. Yes, you want to treat everyone as though they might struggle with health information. But if you can get some kind of data to help you understand who has limited health literacy, then it might help you use some limited resources for those groups. So if you're in a value-based reimbursement structure that gets some per member per month payments for care coordination or something along those lines, then you can't really offer that to everyone. But if you know that the person in front of you struggles with health information, they would be a great candidate to receive your care coordination. We actually have some of our CPC Plus practices that are thinking now about adding the patient level health literacy score into their overall risk score for their patients. So that can be useful as well. I love this image. You can YouTube this. If you YouTube Dr. House, Are You an Idiot? You'll find this video. It's great. So being the smart aleck that he is, he asked this woman, who comes in with exacerbations of asthma. He says, well, are you sure you're using your inhaler correctly? And she said, well, yeah, I go through like 2 a week. And he's like, huh. He said, well, why don't you show me how you're using it? And she proceeds to, apply the rescue inhaler to her neck as though it were perfume. And so as much of a smart aleck as Dr. House is, he did a great thing in confirming patient understanding. And you can only do that when you ask a patient to show you or tell you. asking, do you understand, or what questions do you have, or do you have any questions, is simply not adequate. But unfortunately, it's what we see time and time again. I have a second year medical student who's working with my office right now on a couple of projects, and she called the other day just really upset. She said, I'm at one of my clinical, practice locations out here in the field, and I'm just really angry because all day I've watched the doctors come in and dump a bunch of information out to a patient. And as they're backing up toward the door, say, you have any questions? And of course, the patients and the family members say, no, we're good. And the patient, the doctor leaves and the patient leaves. And she said, I know these patients don't understand a thing that was discussed. And that really bothers me. And I said, well, you're right. It should bother you. So a health literate organization really integrates teach back or return demonstration as part of that staff training and part of that, part of the culture in clinical care. So some of the specific things that organizations often need to provide in terms of education beyond the traditional self-care and wellness type education: how to navigate your services, how to find you physically, where to park, perhaps if you're located in a large campus like our primary care practices are. All of those things, finding their way around, getting other care from other parts of your organization. Again, more true in a large organization, but certainly true for all of us. That written information, whether it's online or something that you print and out with an after visit summary or otherwise to share with patients, really making sure that that's been vetted for plain language. And again, those are not skills that people come out of school doing. I'm a health educator by background and training. I think that up until 6-7 years ago, I could articulate why it was important for health information to be written in a way that people could read and understand, but I'm not sure I could do, I know that I couldn't get it completely in great shape in terms of plain language. I could run some readability stats and maybe make a pass at getting rid of some jargon, but that's about as far as my skills went until I was exposed to more nuanced plain language writing and all the technical aspects that go along with that. So that is something to be mindful of. Really dealing with health literacy in high risk situations. And, this involves care transitions and communicating about, particularly high risk medications and things like that. And just making sure that there's a solid educational plan in place to avoid those potentials for patient safety errors to happen. And then in these really high risk areas, this framework also recommends doing some audits. So taking a look at the patients who came through your practice in these high risk situations and looking for evidence, looking for documentation that quality education was in fact provided. And then this last one is interesting, talking with patients and prospective patients about what they might have to pay for in terms of services. And I know that hospitals in particular have some new requirements from CMS to provide some transparency around their pricing. And if you've seen any of those, well, they all look similar, the ones I've seen so far. It's an Excel spreadsheet with a lot of acronyms and long words that most of us on the call wouldn't understand. So in terms of it being a useful tool for patients, probably not yet in most cases, but that's an opportunity and gives us something to focus on as well. And this is just a testimonial from a health communicating organization who really does fit the bill of being an advocate for clear health communication. They just have it as part of their practice that everything gets formally reviewed in terms of written information before it goes out to patients. They've done staff training to help their staff identify when something is not as it should be, and they encourage teach back and lots of other things. So there are some champions out there, and I'd be glad to connect you to those. But one thing that I wanted to make you all aware of, and I'm going to drop this URL in the chat. October is Health Literacy Month. And so if all of this so far, you're just like, geez, that's a lot, where would I start? Start with the fact that it's in addition to Rural Health Month. I think I heard on the earlier presentation, it's also Health Literacy Month. And so we've got a few things at the URL that I posted in the chat. that you can go out and grab and share with your practices. Out on that website, there's a poster, a printable poster that you could just have printed for your practices and have them stick in their break rooms that says, hey, this is why you need to be paying attention to health literacy. There are some talking points. So for folks that have regular staff meetings, just a few little, hey, I've got a quick announcement, let's talk for 5 minutes about the importance of clear health communication in our work, just to kind of start the awareness. And then this one I think is more fun, the plain pledge. So you can see this young woman here taking the pledge, but this is everyone's opportunity to commit or recommit to avoiding jargon in their health communication. And so if you, again, go out to our website, you can download the little buster sheet and print it, or you can just have people draw their own. But I think it's a really fun way. People have to stop and think like, okay, well, what word? And I see there's a question from Ashley already in the chat. What word would you stop using in your communications? So you can think about that and drop those in the chat. We can have some fun with that. But because we have our jargon, and it's not just scientific jargon. All of the sciencey words are obvious jargon, but we have other words like provider and the patient presents with and ambulatory. Those aren't scientific words necessarily, but they're health industry specific. And people that don't work in our industry don't speak like that. And then there's sort of another rung of jargon, I would say, and that's words that maybe aren't even industry specific, but they're still not living room language. So if you want someone to start taking medication on day 7, don't say commence taking the medication on day 7, because that's not how we speak in everyday conversations. That's not how we speak to our grandparents at the dinner table. So this is a fun activity to just kind of make people aware of all the jargon that we do have, all of us do in our work, and to really commit to avoiding that jargon when they speak with patients and families or write for patients and families. And so you take a selfie, you can put it on your own social media. We love it if you tag us, because we like to keep up with folks around the country that are using it. That's really fun for us. Unprecedented. That's been a great one. I'm looking at some of these words. Unprecedented has been a great one during COVID for sure. What does it mean to be effective or evidence-based paramedicine? Okay, someone would have to explain that one to me. That's a new one on me. I don't know what that one is. So even amongst professionals, and that's where some of the problem happens, right? Like we learn, whatever your health-related profession is, you learn a new vocabulary throughout your training, and you're expected to use it when you communicate with your professors. You're expected to use it in your academic writing, and then you're expected to just flip a switch whenever you are in front of patients and families. And this is true for every level of staff, right? I know, when we think about health literacy, we tend to think about those direct patient care staff, your nursing staff, your physicians, and trainees. But the person that sets those appointments over the phone, the person that guides someone through their first telehealth visit or video visit, the person who provides the directions in your marketing department, all of those people, your billing folks, all of those people have opportunities to avoid jargon. So this is an activity that you can use with anybody in your health organizations. So everything is out there on the web. Grab it, use it, tag us. Let me know if you have questions or other ideas for Health Literacy Month. If this sparks something in you and you do something really cool, I'd love to hear about it. We'd love to give you a shout out on social media and share that opportunity with other people. So these are some resources that I think you will find helpful. So the 10 attributes of the health literate healthcare organization. It's a really long URL. I promise if you Google it, you'll get there faster. Same with the health literacy environment assessment. That is a great place to start, to just see like which of these attributes might our organization need to kind of start with based on where we stand and what we have the resources to accomplish. Plainlanguage.gov has a lot of plain language writing tips that you can share with organizations. The CDC, at their site, they have some good background information on why health literacy is important in healthcare. And they also have some good information on, they have a course for numeracy, so sharing numbers in healthcare in a way that's understandable and valuable to folks. The teach back method that I mentioned a couple of times, that's from the AHRQ. There's some teach back training available online. And then us at the Center for Health Literacy, we've got, like I mentioned, the how-to booklets and online modules that are, those modules are free use. I'll ship you booklets if I have them, and all those Health Literacy Month resources as well. So we do have a little blog. We don't inundate you with messages. It's usually one a month, and it's usually some kind of really focused plain language delivery tip, either a tip for spoken plain language or for written plain language, but we won't inundate you with stuff. And then we're out on social media as well at all of those platforms. So we would love to have you follow us there. And we would love, if someone's asking, can we unmute and provide comments? Absolutely. It sounds good to me. We would love to see you active in Health Literacy Month this year. And then I've got all these references here in your slide deck. So Sarah O'Connor says she's a College of Public Health alumni, now working in Richmond, Virginia. Glad to be connected with you, Sarah. Hope you'll connect back with us if you're not already. All right. Let's see. I cannot see everybody. So Ashley, if you can see if their hand up or is unmuted.
Well, this is Lisa Davis. I'm the one who asked if we could just talk extemporaneously here. Allison, thank you so much for your presentation. It was great. I just had two quick comments. One is I've been a really firm believer that every single person, regardless of any adjective that describes them, you know, their demographics, their age, their sex, whatever, their level of knowledge, needs to have a patient navigator. And I thought maybe you as a health educator might appreciate that for all the reasons that you just mentioned. You know, even those of us who work in health policy or who work in healthcare go completely and absolutely numb when you are in a room and it's you or your kid or whatever. And how often I wish that I had had somebody out there to ask the really, really stupid questions and have someone answer me. So that's one comment. The other is, I was glad to see that you had the CDC on there with their health literacy links, but I really do feel like with a lot of the information that's come out, especially around COVID, it has been so dense in many respects, right? I just have sort of stopped looking at it. And we're now trying to make sure that we're developing COVID messaging because we're getting, like all state offices, we have CDC funding to do that. We're trying so very hard to make sure that we are developing or modifying existing materials that are very responsive to all the populations that we serve in Pennsylvania. So I just, you know, I admire the CDC so much, but
yes,
when you believe that you're being completely,
I agree with you. I think I do place a lot of value in some of their online professional training materials. And I can't say that I did or did not include any CDC information in our assessment that I talked about earlier with COVID materials, but we will say that they were the ones that we reviewed were like the top searched, the ones that came up first on your search engine across the 4 big search engines. So there were absolutely some national organizations and a lot of state departments of health whose information was included in our assessment, which proved dense. Pictures that showed it was all about what you can do to protect yourself, and all the pictures showed people congregating with no masks. We've seen them. So yes, just because it is from a certain organization does not mean that it is great quality to share with patients. I'm putting in the chat Immunize Arkansas. It's our state immunization coalition. They have posted some COVID vaccine community workshop materials that our office developed in partnership with our state Department of Health that are very, they are comprehensive from a health behavior theory standpoint, in that the populations that they're intended for, Spanish speakers, Marshallese, and African Americans in rural Arkansas. They were all built around the kind of the the barriers that those groups had expressed through surveys and focus groups surrounding considering the COVID vaccine, and then that played on the benefits, that the people that came to those focus groups and said, yes, we do plan to get those vaccines and here's why. So there are some materials out there. There's a slide deck. It's really meant for like a layperson, a non-healthcare worker, community person, a pastor, someone like that who wants to lead a COVID education session in their communities. But there's a community workbook that, you know, calls for some kind of inner reflection and a slide deck. So those are out there. And yes, you can use those in other states. Absolutely. You can download it. Now, the information that's there is probably going to, if I remember right, we have some Arkansas specific data, but you know, it's out there. It's out there for the using if there's any pieces of it that are useful. And then to your point about having a navigator, Lisa, I think, you know, that's one of our recommendations in the How to Talk to Your Doctor handbook under the list of what to bring with you. It's to bring someone with you who can help you take notes, who can help you ask the questions that you wrote down that you forget to even pull out of your purse because the white coat syndrome happens or you don't feel good or whatever. And so we definitely advocate that folks bring someone with them to serve in an advocate role if they're able. And I know that COVID's made that very difficult. And so I think it's something that people will have to get used to again. I think we've all gotten used to going into those situations on our own again. And I think that's going to be an opportunity for retraining for sure. Thanks for those comments. What other questions or comments do you all have? I know we're about out of time, but we have time for another one or two. Well, I encourage you to think about which of these resources might be most helpful for your practices and make a plan to start sharing some of that. You know, it starts with awareness. You're not going to change the world in a day on any of these issues. And you all have so many issues that you're providing assistance on with your practices. And this is just one of them. But I hope you're leaving feeling like it's a worthwhile one to address and with some free, ready to use resources out there that you can tap into and take advantage of. And if I can help you in any way, I hope you'll reach out to me directly or send us a message through our website. We'll be happy to connect.
Thank you, Allison. This was excellent content for our members. We really appreciate you taking the time to come and present and give some great resources too. As I mentioned at the beginning, we did record today's session, so we'll have that recording if there's anything that you want to go back and see or catch some of those resources too. Even I was jotting down notes the whole time, and you know, some things that I want to think about for NoSOR as an organization too. I think there's some room for improvement. So thank you again. We do have a break coming up right now from 4:15 to 4:30 Eastern time. So just stretch your legs, get a snack, go back to Crowd Compass, the app, and you'll find the link to go back to that general session at 4:30. So thanks, everybody. Thanks, Allison. Bye.